Name's Dr. Sinetsehay Temesgen, presenting today a lingering acidosis caused by an SGL2i inhibitor-associated glycemic decay. Since their approval by the FDA in 2013, these drugs have demonstrated a wide array of benefits, which could range between improving glycemic control to reducing all-cause mortality and cardiovascular mortality. And they are coined the term euglycemic, reflecting a less than anticipated blood sugar levels. Today I'm presenting a 41-year-old male patient who developed a DKA with modestly elevated blood sugar levels. This patient was initially diagnosed to have type 2 diabetes 2 years ago, and with last known hemoglobin A1C of 7.1, also has a past history of hypertension, presented on the day of admission with fatigue, nausea, and vomiting of 1-day duration. He was reported to have a DKA in the past, which he was placed on insulin briefly. He had to later be switched to oral antihyperglycemic agents due to inconvenience related to work and personal preference. He otherwise denied any significant past surgical history. Father had diabetes type 2 and also denied any smoking, alcohol use, or illicit drug use. And he's in a monogamous sexual relationship with his wife. Medications are as stated: metformin 1 gram BID, Jardiance, and atorvastatin and lisinopril. So this patient presented with poly symptoms. He also reported that blood sugar measures that at home of sporadic measurements, 150 to 200, but with a week leading up to hospitalization, elevations of blood sugars above 250. He was adherent to medications. Rio systems showed that he had intermittent dry cough for about a week and a left inguinal lesion of the same duration. Physical exam mostly prominent for tachypnea and tachycardia, and showed that inguinal peripheral lesion, which was producing mild serosanguinous discharge. Otherwise, lab work reflected a high anion gap of 33 with pH of 7.14 and beta-hydroxybutyrate level of 9.4. His blood sugar level was 408 mg per deciliter at presentation, and there were also pseudohyponatremia, hyperkalemia, and an AKI, but otherwise the lactic acid, salicylate, and ethanol levels were pristine. His complete blood count also showed a leukocytosis with left shift. He was kept MPO and started on impric antibiotics while workup continued for potential precipitants. Blood sugars improved immediately within 2 hours of fluid resuscitation and insulin initiation to 200. While anion gap seemed to show some improvement with subsequent chemistries, but a stagnant course. Patient's inguinal boil on the second day improved, while his white count also normalized and his remaining labs also normalized. And his insulin drip had to continue with dextrose IV fluid due to the remaining anion gap elevation. On the 4th and 5th day, patient showed complete clinical improvement in terms of symptoms. And lab work also showed improvement in all parameters apart from the anion gap, which remained at 18, and a bicarbonate level of 40. He was subsequently transitioned over to subcutaneous insulin, and then adjustments made throughout hospital stay. Patient had to be discharged on day 6 of hospital stay due to personal request, and due to with agreement to follow up with his endocrinologist immediately. And on day 6, his anion gap still was at 17 and bicarbonate level was at 17. So basically, this DKA is a rare complication that occurs in less than 0.1% of patients with type 2 diabetes treated with these drugs. And it's shown to have 1 in 1,000 patient years incidence in randomized controlled trials. The cause and the pathophysiology is not well understood just yet, but proposed mechanisms include impaired excretion of ketones, sudden transient impairment in beta cell glucose sensing leading to absolute insulin deficiency, stimulation of alpha cells to produce glucagon are among a few theories going on. So the longer lasting acidosis was also described in few case reports, including a Korean case report attached DOI here. So the recognition of the presentations with subtle blood sugar elevations and the protracted nature of acidosis is a challenge to clinicians, but these drugs have grown beneficial in diabetic patients with cardiovascular disease as well as renal disease, and a notable adjunct to blood pressure management. with the growing utilization of these drugs, precaution needs to be taken before initiation and with continued use. And there's a clear need for research to investigate the causes, but and also understanding pathophysiology, but clinicians need to recognize not to start these medications in type 1 diabetics and ketosis-prone type 2 diabetic patients, and also focus on avoiding these drugs in case of anti-regulatory situations like fever and trauma and surgery, and also not to start it in patients with a history of DKA. This patient had a history of DKA, which likely indicated poor candidacy for the use of the drug.